Presenting a literature review on the prevention of venous thromboembolism in hospitalized patients as part of Professor McGill's St. Petersburg College course in summer of 2026. This will be a literature review in which I will synthesize current and scientific research on this topic. My sources are published within the last 5 years and peer-reviewed from professionals in the field. Venous thromboembolism is a disease entity characterized by the formation of blood clots in veins. This would include DVTs or deep vein thrombosis and PEs or pulmonary embolism. This is a significant topic because the incidence of venous thromboembolism in hospitalized patients not receiving appropriate prophylaxis is estimated to be 5 to 15%. And hospital-acquired VTE is often cited as the most common cause of preventable death in the hospital. I created kind of a potential illustration of what could happen if a patient is admitted to a hospital, there's no VTE prophylaxis administered, and 1 week after discharge, a DVT is discovered by the patient's care team. For my literature review, I used the St. Petersburg College Library database. I searched the phrase venous thromboembolism prophylaxis in hospital patient, and then I refined by dates, so published after 2021, open access, available online, and peer-reviewed. The first source by Crossman and colleagues in 2022 is the association between time to first dose of venous thromboembolism prophylaxis and the incidence of hospital-acquired venous thromboembolism. This was a quantitative retrospective cohort study. It's observational in nature. It was a chart review of over 9,000 patients admitted to hospital from the emergency department in Weill Cornell Medicine in New York in 2019. This is level 4 evidence according to Gray and Grove's hierarchy of evidence. So their finding was that there was an increased risk of hospital-acquired VTE in hospitalized patients that do not receive their first dose of VTE within 96 hours. At first, this sounded like an extremely long time, but I thought about our emergency department, our high rate of border patients and PTOT hold patients that might not have admission orders started in a timely fashion. So I could definitely see in a hospital that has a high rate of boarders or hold patients how this delay could happen. The second source by Nick Vars and Site ED conducted in 2022 is the improved utilization of venous thromboembolism prophylaxis in renal impaired patients following a clinical pharmacist intervention. So this was a quantitative prospective cross-sectional study, level 4 evidence. They examined the charts of 64 patients over 2 3-month periods in a nephrology unit. So the first period was before intervention, the second period was after intervention. They had a pharmacist around with clinicians as an intervention and recommend specific VTE prophylaxis with the clinicians. So their finding before this intervention was that thromboprophylaxis is used in less than 40% of high-risk medical patients in the nephrology unit. So these are perhaps like end-stage renal disease patients, patients on dialysis, patients with severe acute kidney injury. And their findings were that the recommendations of pharmacists significantly increased the proportion of high-risk patients who received thromboprophylaxis and reduced the proportion of low-risk patients receiving anticoagulant drugs. One of their recommendations was that there is not a specific risk assessment model for patients with renal impairment for VTE, and that time should be spent developing a specific risk assessment model for these patients. My next source by Shaw and colleagues from 2022 is Risk Assessment and Prophylaxis of Venous Thromboembolism in Patients of Medical Ward of Northwest General Hospital and Research Center, Peshawar, Pakistan, a Quality Improvement Project. So this was quantitative study. It was quasi-experimental, level 3 evidence. It was conducted in Pakistan. They found that a simple educational intervention markedly improved the patient care related to VTE risk assessment and prophylaxis. Later in this presentation, I talk about their baseline prior to their intervention, which was like a short presentation on VTE prophylaxis. They found prior to this intervention only 5% of patients were receiving VTE prophylaxis, were being assessed for prophylaxis, and only 22% of those patients received VTE prophylaxis medication administration. So they stress that VTE prophylaxis implementation is lower in developing countries, in part due to heavy workload and scarce resources. This is not a finding that I would generalize to the U.S. Medical area, but it was an interesting study. So from two of the sources, they really stress that the use of a multidisciplinary team approach in the management of patients will significantly improve the rate of VTE prophylaxis prescription. As a nurse, I say that nurses play an important role as nurse advocate for patients to receive VTE prophylaxis medications and interventions such as sequential compression devices, and that clinical audits are informative to determine opportunities for improvement of clinical practice. So here's the numbers from the Pakistan study. Only 5% of patients were risk assessed for VTE prior to intervention. In all of the studies, though, they pointed out the hesitancy for VTE prophylaxis due to risk for bleeding, the need for continuous education on VTE risk assessment and VTE prophylaxis. Some of these studies had very small sample sizes that prevent the generalization of findings, but I found that each study was helpful and there's information to be gained. In conclusion, VTE prophylaxis should be started in a timely fashion within 24 hours of admission for patients without contraindications. Nurses should be reviewing orders, messaging doctors, asking about VTE prophylaxis for their patients, considering the risk of GBTs and PEs to the patient's health. It is important that further research be conducted. Prospective multi-center clinical trials would be helpful to find information that can be generalized to greater populations. This study by Schellenberg looked specifically at VTE prophylaxis initiation in trauma patients, and they found that once clinical and or radiographic injury stability has been confirmed, VTE prophylaxis should be initiated. This kind of spoke to the concern for bleeding in patients with trauma, but they found even traumatic brain injury patients, abdominal trauma patients, spinal injury patients benefited from VTE prophylaxis. These are the resources that I use listed for you for review. I want to say thank you for watching my presentation, your time. I look forward to comments and any feedback. Thank you.